Hi, everybody. Can you hear me? I see 2 people, 3 maybe. Sorry about getting the meeting started. I thought that they were going to just have us talk for 15 minutes, but they never said break into your small groups. How many people do we have here? Why doesn't everybody say hi and unmute for a second?
Hi, this is Jean Lithgow. I'm here.
Where are you from?
Rayford, North Carolina.
What's that near?
Fort Bragg, Fayetteville.
Okay, fair enough. We got family in North Carolina. Who else is here?
My name is Rachel. I'm from Fort Worth, Texas. Can you guys hear me?
We can hear you.
Okay.
I see somebody else with a cute baby.
My name's Elaine. I am in Denton, Texas, and this is Leonardo, and he doesn't want to get put down, so he's going to be here.
Join the group, Leonardo. That's always very sweet. A little more work for you, but we're happy to see a baby. So there's supposed to be 6 of us. I don't know where Randy is. Let me just take a second. And they said that we can do however much time we want. So do other people have a sense of how much time they want to put into the conversation? Were you all watching the other larger conversation as well?
Yes.
Yeah, it's still going on.
Mm-hmm.
Okay, give me 2 seconds to see. I'm just going to minimize this to see where other 2 people are. But if one of you wants to start, I think, given that we're from all over the country, just to say what is since they're supposed to focus on the cost of care, what's the big thing you're seeing where you work or from what you're studying? I'm just going to minimize it, but you guys keep talking.
Yeah.
Okay. So she wants us to go ahead and talk?
Yeah,
right?
go ahead.
Okay. So as the bigger group was saying, one of the things I see is that I think we order a lot of unnecessary tests and procedures, for the patients, contributing to some of the costs, the increased costs in healthcare.
I don't really see too much abuse of tests and procedures. I work in an open heart surgery intensive care unit, but my whole project for my DNP has been about blood conservation, and that's huge. Some of the research I found, says that a hospital system in Virginia reported like $49 million in savings over 2 years by proactively reducing their blood usage.
Could you say that again, Gina? I couldn't. Proactively reducing what?
Their blood usage in cardiac surgery patients. So they implemented some blood conservation measures and were able to reduce their transfusion rate, and that translated to like $49 million in savings.
So what are you doing with that with your DNP project?
So my project was about trying to implement some of those preoperative, proactive blood conservation measures. Unfortunately, I didn't have great participation with that. So,
has anyone examined the legal aspect of restraint of trade? Does anybody know the answer to that? And how that would...
Welcome. Glad you found us. Randy, do you want to introduce yourself to the group and just say where you're at? And they weren't clear on the other call. I don't know if you saw my message that they said, oh, just start anytime. You should leave the main one. I think we were all hanging out at the main one.
Yeah. Hi, guys. Can you hear me?
Yes.
I'm Randy Pellu. I'm a nurse practitioner in New York, and I practice at Long Island Jewish Medical Center. And I've been a nurse practitioner for about 2.5 to 3 years now there. Great experience, and now completing my DNP, so I'm hoping to take this another step forward over there.
Welcome. So who hasn't talked yet? I know, Randy, you haven't and I haven't. Elaine, do you want to go and talk a little bit about what you're seeing as a cost of care issue for you?
So I'm a relatively new practitioner. I've been a midwife for about a year now. And my experience with cost of care is really limited, partially because ever since I've been married, my husband's been in the military. And so I don't have any personal experience with cost of care because everything has always been covered. I've never really had any concept of what care costs. And then again, at the birth center that I work at, a lot of our patients are cash pay. I actually found myself saying, I have no idea, go talk to the billing manager, that has nothing to do with me, because I truly just don't have a concept of what healthcare costs are. I was really surprised to learn the other day that many of the insurances that we do carry do not cover ROGAM. And I just don't understand why. It floors me that they would rather pay for a sick baby than prevent a problem in the beginning. So I don't have much experience with it. I'm interested to hear what everyone else has to say.
Oh, interesting. From my point of view, my cost of care issue will focus more on the frequent flyers that show up in our emergency room. Practicing, some days I would see the same patient showing up 3 or 4 times, believe me, 3 or 4 or even more, for nonsense. I was just here, I feel bored, or I'm feeling anxious, or I'm feeling depressed. And having these repeated offenders over and over again, and I'm wondering what impact do they have on our insurance policy? What impact do they have on taxpayers? So my hospital, per se, they set up a program. They have a liaison currently now who is her job is to specifically identify these people and see if we can find a program outpatient for them. Set up certain therapies, set up certain group sessions that can keep them out, because every time they show up, the hospital or the insurance is being charged for emergency visits, and you guys know how expensive that can be. So that's one of the major factor, one of the biggest problem that we face in LIJ in New York.
I think those are all, I think there isn't any question. It was interesting talking, or just listening anyways, to the leaders that they had on the main talk in terms of, hey, we've been working on this for 60 years and longer, and what does that mean? We know that our healthcare system is broken, but how we fix something, Randy, I think what you're saying is really critical. Like, how do we make sure that the right people are getting the right care? Same thing, I'm just fascinated with this idea that we're not using blood appropriately, that you could actually find ways, because you just have that misconception of we only give blood when you need it. And that somebody actually was able to think through that we were losing money here, I think is just really important. Elaine, I remember how I felt as well, that like for the first few years when I was a nurse midwife, I just was like, I'm new, I really don't want to know, I don't really, it's like it's too much, somebody else deal with it. And then, as you get into it over time, where I really see the issues are that if we know what our patients are being charged, then that's part of the service we provide. I had a horror story happen with my own daughter. She is in Europe. And so she was home for just a very short period of time. She has an IUD. She went in for her annual check. I live here in Pima County. You can go to the Pima County Health Department and get an STD screen for $40, a complete screen. But we have insurance, so her provider, an incredible women's mental health practitioner that I just love, ordered an STI screen. Can anybody guess how much they charged us for a basic STI screen?
Yeah.
Somebody take a guess.
Like 1,500?
That was good. You're from New York, right? So, $500 for
Oh my
something
God.
that costs $40 out of pocket.
Yeah.
And it's all because they had this proprietary BV, bacterial vaginosis screen, included in the mix. And you can tell that the insurance company, the lab, is just trying to make money back from this BV, screen. I fought for 6 months trying to say, we do not, that's ridiculous. It costs more than our IUD. So that's the kind of thing that I worry about is in this for-profit system. And Elaine, given that how many patients you're seeing and then they all have different health insurance, how do we create a system where those costs are more transparent, that there aren't those surprises? What else are you all feeling about that? Or is there something out about the cost of care that...
Another big one that I see in my emergency room is the use of simple serum HCG compared to urine, a pregnancy test from the urine compared to a pregnancy test from the blood. It's like $500 compared to $10. And I find that a lot of providers have been, been ordering serum HCG. Guys, why just do the pregnancy test from the urine? So that's another big thing we're trying to look at, just specifically try to reduce costs by using this cheaper, simpler test.
Rachel, do you want to say more about what you're seeing and anything that really strikes you about where we could reduce costs?
Well, I'm a nurse midwife. I'm all on board. I currently work at Harris MFM clinic. But I do see a place for, low risk women being out in the birth center setting, as they say, and then the higher complicated patients in the hospital. And that I feel like would go a long way in cutting down on costs, especially in the maternity area. Somehow we could, get more women who are healthy, to use those kind of settings and stay out of the hospital and leave that for people who are, having more issues.
Rachel, where do you practice?
I practice at Parkland Hospital. It's one of the bigger hospital. We probably average about 12,000 deliveries a year. So.
Oh, what state is that?
It's in Texas.
Oh, okay.
Yeah. Yeah.
Jean or Jeannie, tell me again how you say your name.
It's Jean.
Jean, what would you think about, I think one of the things that's so interesting in our system when you listen to all of our stories is just this idea that who decides what care is provided. Like there's no real mechanism right now. Anybody can walk into the ER as many times as they want per se, or then what do you do when the healthy woman who really could be a good fit for the birth center? How do we create a system? Do we go to universal health care or what do you think?
Well, I don't know. And I actually see that get abused a lot at my my place of employment now. So we literally have an emergency room on one side of the hospital, and on the opposite side of the hospital, we have an urgent care. And the idea was that, maybe more people would redirect themselves to the urgent care for things that don't truly warrant an emergency room visit. However, for legal reasons, if a patient walks into the emergency room with a toothache that could be taken care of over at the urgent care, they are not allowed to suggest that they go to the urgent care. They are not allowed to offer to take them to the urgent care, even though it is in the same facility, owned and operated by the same hospital, same physicians, everything. They can't do that. And they can't even say things like, if you choose to stay here in the emergency room, you might wait 12 to 14 hours to be seen. But if you go over there to the urgent care, you'll be seen within the hour. And it's just, I don't know how to fix those problems where people don't seem to understand that as much of the problem is how healthcare is run as it is how it is used, how consumers use and abuse it.
Yeah.
No, I agree. And that's a fascinating thing. You think in a functioning system, you could say, go over to the urgent care, and if you need to be in the ER, they'll send you back over here, right? That's, go ahead.
So
That would be the case.
So then on one hand, I definitely see the client abuse, but on the other hand too, I feel like these insurance companies, it's such like a profit driven thing that I think it has just blown the cost of healthcare through the roof, as it's more about making money. I don't know, what do you guys think?
That's a good point, but I agree. I think that as providers, we have to be cognizant and be aware of how we're prescribing and what we're doing. Because sometimes we go above and beyond and ordering all these unnecessary tests. Are they really needed?
Mm-hmm.
Like I see one every day, like for new onset psychosis. I mean, of course, a CAT scan is recommended. Whenever I call for a psych consult, almost every time the psychiatrists are asking, can I have a CAT scan? Can I have a CAT scan? And rest assured, guarantee you, let's say I see 100 people, 0 has an organic cost related to the psychosis. It's either drug, substance, or maybe like a family history. So we have to be so much aware and cognizant of what we're prescribing and not to overprescribe.
I agree. I see that on my.
You say ordering then, not prescribing. Ordering, what tests we're ordering.
Hey, Michelle, welcome. How is it going now with your internet?
It's kind of hit and miss. You guys are breaking up a lot.
Yes, we can hear you.
Yeah, you were a little bit too. Just tell us where you're at and if you had something you really wanted to say about cost of care and what you're seeing in the work you're doing.
Oh, great. Yeah. So I'm Michelle McMahon. I'm in Prescott, Arizona, which is near nurse midwife. So not quite working yet. So really, I don't really understand about the cost of care since I'm all in works. But I am interested in changing from, a volume-based type of payment system to an outcome-based type of system.
Mm-hmm.
And I just wondered what you guys thought about that.
I think it's a great question. What does everybody think? I mean, I think in our dreams we would have an outcome-based system instead of volume, but
yeah, I mean, if we went to an outcome-based system, we'd have a much healthier population.
Mm-hmm. Very good.
Elaine, what do you think?
I didn't hear her question.
Her question was, could we go from a volumes-based system, how many people you see and how much you get done in terms of procedures and things like that, to an outcome-based system?
Well, if that was the case, again, my experience being only limited to a birth center, that would be fantastic for us because we have great outcomes.
I think that's a good idea to look at the outcome base, but we have to be realistic. The way these hospitals are running, my God.
Yeah, I mean, that's kind of a big deal in my environment. Like I said, I'm in an open heart surgery intensive care unit. Unfortunately, we do sometimes have bad outcomes that don't have anything to do with the care that we've given. Yeah. It's the fact that when patients came in, they were so sick and they've had massive heart attacks and they have such poor cardiac function, they can't survive without ECMO, and they get all this blood, and then that contributes to their mortality. And at the end of the day, the patients don't survive. So it's a poor outcome but it's not tied to the quality of care that they receive.
Good point.
That's a really good point. And I think another thing that happens when you focus on the outcome is that you're putting all of the responsibility on the provider and you're not putting any responsibility on the patient. Because
Absolutely.
many times we see bad outcomes and it's because, well, but you didn't follow your diabetic diet or you didn't come in for your blood pressure checks, that kind of thing.
Right.
I'm going to do a quick time check for the group. We've been talking almost about 25, 30 minutes. I'm happy to keep going, or I'm happy to say we met the objectives, and I will send everybody the link, and that's your proof that you were here. But what else? Do people have more they want to say or talk about? Just let us know.
I feel like this was a beneficial conversation.
Yeah.
I agree.
Me too.
Me too. Even though I was late to the game.
We didn't hear from that little gentleman there, though.
Julio, he's been stabbing me with these little
Hello.
I was impressed. And Randy, it looked like you had somebody little run behind you. You got anybody there with you?
Yeah, she went to bed. That's my daughter.
All right, well, I would say good job. I do feel like it's nice to have a reason to talk, and even though there was a topic we were supposed to talk about, it's nice to not have it be a strict assignment per se. It's kind of cool that we're all from all over, too. I like that, too.
Yeah.
So
Okay.
thank you, everybody. Anybody, any last comments? Otherwise, I will stop the broadcast,
Lisa.
get the link, and send it to everybody.
Okay, thank you.
Good. Have a great night, everybody.
Good night.
Okay, bye-bye.
Good night.
Bye.